Thank you very much, Rob, for this kind introduction, and thanks also to give me the first to speak today. I'm very delighted to have an audience, a live audience, as it's probably a year and a half that I haven't talked to anybody, so except virtually. So I'm very glad of that. So yes, let's start. So as not everybody of you work on hematopoietic stem cell, I thought I put some very general slides at the beginning. So this one essentially is to show that this is the normal hematopoietic stem cell hierarchical structure with the hematopoietic stem cell here at the top, which are giving rise to whole blood cells over the lifetime of an individual. And we have characterized a different population of progenitor that have actually a role in providing, rapid response to any infection or emergency. But really, the key population is the HSC, which my lab and of course a lot of people are interested in, as this is the only one that gave rise to long-term self-renewal capacity. At the same time, we are looking at leukemic cells, so mostly my lab is interested in myeloid leukemia, and we are going to listen about both myeloid dysplastic syndrome and acute myeloid leukemia. What we are more interested in actually in this disease is the fact that we ages ago, now I don't want to say how many years, we essentially demonstrate that the leukemic cells is also developed into a hierarchical structure where at the top there's also leukemic initiating cells or leukemic stem cells that have very similar property as normal stem cells, as they self-renew and they maintain the disease long-term. They also differentiate into the leukemic blasts that essentially fill up the bone marrow of the patients with leukemia, but they have also the property of this leukemic blasts are very limiting differentiation capacity. And I will also discuss the idea of that these, because they are not producing any mature cells, have also an impediment on the patient to produce erythroid cells and blood cells for the life of the individual. So these leukemic stem cells, we found them actually originally as, very similar to the normal stem cell phenotypically. Since then, a number of people, including ourselves, have found that leukemic stem cell phenotypically are very heterogeneous. And with next generation sequencing, we know also that genetic heterogeneity exists, not only just between patients that have different mutations, but also within patients, there's more than one leukemic stem cell clone with actually more heterogeneity even, because at diagnosis, you can have a pool of leukemic stem cells, but these evaluate over time, mostly based on chemotherapy. So that's what we call it the Darwinian evolution. Has this acquisition of mutations is essentially always in a selective pressure by either chemotherapy or extracellular factor like infection, etc., that will actually increase the heterogeneity of this compartment, making it a very complex, nonlinear clonal structure. And the thing that I also wanted to mention, which is probably a little bit more that we have found more recently, we and others, is that there's also a founder mutation that exists, which we call pre-leukemic stem cells, that actually are important also to keep in mind, because you can kill all the leukemic stem cells, but the pre-leukemic cells that may have just one mutation, the founder mutation, have been shown actually even in patients to also be responsible for the relapse, indicating that eradicating all these leukemic stem cells is going to be a challenging task. Of course, I don't want to be pessimistic, so I put something here that we are working on with Bill Gray in the lab, which essentially Bill was interested in looking at CKS1, CKS2 2 coming in my lab, which is a protein homeostasis that is important for the regulation of cell cycle, but also has an independent role of regulation via the E3 ubiquitin ligase complex. So thanks for screen that have been done by a Finnish collaborator. We essentially, they screened for us the CKS1 inhibitor on a number of AML patients, more than 150. And they found actually that there was a good correlation between high expression of CKS1 expression and the sensitivity of the leukemia, bulk leukemia, to be inhibited by the CKS1 inhibitor and protein relations. So Bill, parallelly to that, started to look into, could CKS1 inhibitor indeed decrease the leukemia burden? And this is what he showed. I'm not going to be in detail about that, but he showed essentially a good correlation, again, that reduction of the leukemic burden with the higher CKS1 expression. Nevertheless, also over patients that have very low CKS1 seems to have an improvement of survival, even though the leukemia burden was the same. So the idea was, could CKS1 be actually more expressed on leukemic stem cells, and could CKS1 inhibitor affecting the leukemic stem cell pool? And that's what he found by doing in vivo limiting dilution analysis and combining chemotherapy, classical chemotherapy in red and green, which is essentially a combination of RC and doxycycline, which is used in patients, and showing that if you treat this patient with this combination, for some patients, as this patient AML 26, for example, actually doxo and RC kill mostly the leukemic blast, but not really the leukemic stem cells. So you have at the end an enrichment of the leukemic stem cells that is residual after the treatment. If you add only, in addition to this treatment, CKS1 inhibitor, you see that you actually promote the deletion or the elimination of the leukemic stem cell pool. And this is also true for these patients. And it shows essentially that in these mice, by adding CKS1 to these doxorubicin and RC, we can actually improve the survival of these mice. At the same time, as we are always interested in looking at the effect of drugs in normal hematopoietic stem cell development, he did exactly the same analysis by injecting this time normal hematopoietic stem cells and treating the mice with the same drugs, doxorubicin, RC, and CKS1 inhibitor, and essentially showed that doxorubicin and RC decreased the level of engraftment over time, but with CKS1 addition, we essentially maintain the pool of leukemics, of normal cells, normal stem cells here. And if you do limiting dilution analysis, you can essentially read out the frequency of normal stem cells, and you can see that indeed we protect more the normal stem cell pool by this addition of CKS1 inhibitor. So I conclude this by saying that he did a lot of molecular and proteomics analysis in order to understand the mechanism of the action of this selective action on normal versus leukemic stem cells, and essentially show that the CKS1 inhibitor in normal cells actually slow the protein translation, inhibit their proliferation, but also decrease the differentiation capacity of these cells, which is quite good when you look at reducing chemotoxicity. On the other hand, in leukemia, what we see is that the CKS1 inhibitor actually increase the NADPH, and by doing that, increase substantially worse. And we know, based on Greg Jordan's analysis a couple of years ago, that leukemic stem cells are very sensitive to the level of worse. So too much worse, the leukemic stem cell will not survive. So this is something that is under review at the present time, and there will be a poster session on explaining a little bit more CKS1 role in a murine model by Samantha Kitson and Bill Gray. So if you want to know more, I'll invite to go and see them. So as Rob mentioned, my lab for the last 10 years actually has been also interested in not just normal and leukemic stem cells in intrinsic regulation, but also started to look into the effect of the bone marrow niche and what the niche is providing to these cells. And these come actually from an observation that is known for quite some time actually, that the leukemic cells are very powerful in vivo, but as soon as you get the cells out of the patient samples, bone marrow samples, peripheral blood from these patients, the leukemic stem cells are very difficult to maintain ex vivo. So it's very easy to kill leukemic stem cell ex vivo, not in vivo. And the only way to maintain these cells was actually data from Manuel Griesinger, ex-postdoc in the lab, which essentially look at different ways to maintain them ex vivo and show essentially that in most patients, mesenchymal stromal cells were actually able to maintain these cells. At the same time, we had data coming also understanding a little bit the role of hypoxia, which is important for the in the bone marrow niche, showing that if regulators are actually important for the maintenance of both normal and leukemic stem cells. So this is the representation, very simplification of the niche. It's a highly complex structure with a lot of stroma components, but also mature cells that have been shown to regulate normal and leukemic stem cells. When we started these analyses, we didn't know much about how leukemia actually, where leukemic stem cells are, and we still don't know, and also how leukemia impedes the bone marrow niche. And since then, things has improved thanks to a number of groups worldwide. So what we started to do, and that was started in the lab by François Lassailly from the lab, is to try to look into, can we image the bone marrow? Can we look into what is happening? And he developed the vital microscopy, mostly thanks to also data that was developed actually from Christina Lo Celso when she was postdoc in David Scatton's lab. So we recapitulate the calvaria imaging of the bone of these mice and look at the progression of leukemia in vivo. And what we saw actually, maybe I put these, I need probably to get the laser pointer out. Is that the leukemic cells really like to be growing on top of the vessel. And that was image that he did ages ago, and we didn't do anything about that until, and you can see here that the vessels are well structured. When you add leukemia, where leukemia is on top, you essentially lose, seems to have vessels that are destroyed by that. And as I said, these images were done by François, and nobody picked it up until Diana. I showed the picture, and she was very interested in going up to more quantitatively pursuing this project. And she essentially did more analysis to quantify the leakiness that we were seeing. This is the normal. You see very nice structure of the blood vessel. And when there's leukemia with a cell line or patient sample, you see that the contrasting agents pulling out of the vessel, showing that the vessel are being leaky in these patients. So what happened also on the molecular analysis, she went on to look at the endothelial cells from these mice injected with patient samples and taking these to the RNA-seq analysis. And we show actually that it was very specific to AML, because if you inject normal cord blood, you essentially don't see this. And what pathway where there was angiogenesis, increasing VEGF receptor. IF was also present, which was interesting to us. But also, she focused on nitric oxide, as nitric oxide has been implicated in vessel permeability in solid tumors. And she went on to essentially use this DAF-FM, which allowed us to quantify the nitric oxide presence in the bone marrow of these mice. So this is mice injected with nothing, with either covered or different ML patient, and you see that in general there was an increase in all the ML that we've tested. And actually, quite interesting also is that when we treat these mice with chemotherapy, we actually don't see much of a restoration of a normal vessel after 4 weeks of RC treatment. So we went on to our clinician and asked whether or not we can get one more of these AML patients to do the quantification of the same thing, and compared to healthy control cohort, we can also see that in the bone marrow of these patients, there was an increase in NO. And for some of the people, we were able to get it at 2 different times, diagnosis and post-treatment. And if you just look at these grouping every patient together, you see no differences. But if you pair diagnosis and post-treatment for each patient separately, she can see actually there was 2 groups, one where there was a decrease after treatment of nitric oxide level, and another one, the majority of the patient actually did not. And looking at survival of these patients, we could see that, you know, the patient that showed decrease in nitric oxide level in the bone marrow after chemotherapy actually did better over time, indicating that probably even just looking at nitric oxide level in the patient over time could be a pure marker of whether or not they will relapse. She went on to look at inhibition of nitric oxide showing that these allowed actually to reduce the permeability, but also improve the chemotherapy treatment that is given to the patients. So based on that, we were very interesting to see whether we can go translate, as Rob said, we try also to see whether, even though we're using patient sample, we're also using a mouse model. So sometimes it's not very evident that this will happen in patients, even though nitric oxide was increased in the bone marrow of these patients. So there we look into whether or not we can have techniques that will allow us to look at vessel permeability in patients with AML at the clinics. And for that, we essentially discuss with different people and in vivo imaging and the institute, and we find out that, you know, by MRI, in contrasting MRI, so DC MRI, we may be able to indeed look at vessel permeability without having to look at 2 photons on the calvaria of the patients, which will be very difficult to do. Anna Gomez in the lab was recruited because she had done some imaging by MRI in the past, and she ended up looking at whether or not we can indeed look at bone marrow vascularity or leakiness in the mice that we have. And essentially what she see, maybe I need to put the pointer again. So what she saw essentially, even though the mice bone marrow, the femur is very, very tiny, she was able to essentially show that, you know, by injecting in the tail vein contrasting agent and measuring the wash-up of the contrasting agent, this is a normal mice, not injected with AML. And you can see that in most of the mice that have been injected with patient AML, you see that the washout is actually very bad. The peak actually is not very high, which means that the vessel is quite permeable. So that allowed us essentially confirm that DCA MRI should be a way to go to look into patient samples. And I'm happy to announce that we will be entering as of Friday, that we are able to enroll patients at the Barts Hospital for testing these hypotheses, whether or not indeed vessel permeability exists in patients, and whether after chemotherapy we can also see whether or not the patient do better or progress or not. So we have, it took us almost 2.5 years to get all the paperwork, but we are now enrolling patients as we speak. The other thing that we wanted to do is, so vessel was one component of the bone marrow environment. So another postdoc started to look into ways to image all the different components of the bone marrow structure. And she essentially turned to a technique that was actually published by Tim Schroeder from Basel Institute a year or two ago. And she essentially did that in our immunodeficient mice, fixed section of around 300 micron, and were able to do 5 to 6 color in one time with clearing the bones. And you can see here what the resolutions that we can obtain. And she did that with a patient sample at different stage of the disease in order for us to quantify the level of alteration of different stroma cells over time. Unfortunately, because it's a 3D imaging, it took us and is still taking us quite a lot of effort in order to analyze and quantify this imaging. But we're close to the end there. At the same time, similarly, Diana and Antoniana went on to say, okay, we need also to know what is happening at a molecular level in these stroma populations. So we end up doing a reporter in an energy background. So all these has been backcrossed. All these reporters that exist from different stroma population has been backcrossed in energy in order for us to be able to do PDX analysis, and did actually quite a lot of analysis informatically on trying to understand not only which stroma cells have alteration after AML engraftment, but more specifically, we were able to essentially also reveal particular pathway that were crosstalk between not only AML, but different niche at the same time, but more specifically of interest to us was actually to reveal that there was actually also a crosstalk between niche components themselves, and that this was also impeded during development. And if you want to know a little bit more about this analysis, we have repositored everything in this cell report. So that's quite well to say that you are understanding human niche in the context of a PDX, which is still a mouse bone marrow. So we were, of course, aware of the limitation of the model, and potentially what we see in the mice were not necessarily what will happen in the bone marrow of the patients. So we went on a few years back now to try to engineer a humanized niche. For that, we tested a number of scaffolds. It took 2 postdocs actually to find out the best solution. And Ander was actually the lucky one, which came the third postdoc with all the screening has been done before, and was able essentially indeed to show that by using a gel form of a specific collagen-based scaffold, you can actually humanize or seed human stroma cells, both mesenchymal and endothelial cells, and inject that in the back of these mice, and essentially it is able to reproduce actually human ossicles that look like a bony structure. And we were able in this first paper to show that we are able to engraft long-term hematopoietic stem cells and also some leukemia that were actually quite difficult to engraft. So I believe this 3D scaffold will be very important for us in the long term, because it represents a very versatile model for us to look at different components of the niche, but also changing and modifying signaling pathway in this environment to see the result of what is happening in both normal and leukemic development. And we took these further, actually, Said in the audience started to be interesting. He has been interesting in MDS for some times, but there was no mouse model, or mouse model are restricted, and also the PDX model that were usually traditionally done by IV or intra-bone injection didn't really work. So we started to look into whether this scaffold will be useful for this patient that actually we didn't have much model to work with. And so that we receive MDS patients, and it took the mesenchymal stromal cell from this patient, extended it, took some sequencing on this before and after engraftment, did more sequencing also, but also look at the level of engraftment of these different patients. And you look at a bound range of MDS patients with different clinical follow-up. And you can see that in most of the cases, he was able to see good engraftment. What was interesting is that when you look at the bone marrow of these mice, which was engrafted in the scaffold, there was absolutely no engraftment. So the question was, is it because these MDS have problem of migrating out of the scaffold and they stuck in the scaffold? For that, he used a trick to essentially transplant an adjacent scaffold with only the mesenchymal stromal cells seeded, but not the MDS. And you can see that, in this diagram, both the scaffold that were primary scaffold seeded with everything, or the adjacent scaffold, actually we see human CD45, and meaning that the MDS are evolved indeed to reconstitute the adjacent scaffold. And this is a summary of a few mice and a few patients that were done like that. So primary engraftment, but also adjacent scaffold that were empty essentially, but nothing in the mouse bone marrow. And it did actually another experiments that I haven't shown you, which actually also implant mouse mesenchymal stromal cell in the scaffold to show that even implanted in the gel form in the scaffold, the MDS do not migrate to the mouse stroma, but are actually required a human niche for colonization. So this has been published, and of course is continuing to understand what is the factor that are really important for maintaining these MDS stem cells in the scaffold, and what the environment is needed. And lastly, for a few minutes that I have, I also go back to something that my lab has been very interesting for quite some time, which is what happened to the normal hematopoietic stem cells when leukemia is present in these patients. And we know that clinically, these patients are anemic, they have hemorrhage because they have very low platelet counts, they are susceptible to infection. Actually, they die more for infection and all these over anemia than really because of the presence of leukemia. So what we call that bone marrow failure, it's not really the real term, but is essentially to say that normal hematopoiesis, residual normal hematopoiesis, is highly impaired. And David Tosic, which was actually my first PhD, MD PhD in the lab, continued his work in his group. And being a clinician, we were able to essentially obtain bone marrow the first aspirate of the bone marrow of a number of patients in order not to dilute anything and be able to actually quantify the normal residual normal cells, both normal HSC but also progenitor. And what was interesting to see is that, you know, in AML compared to normal control patients, normal individual, essentially there was a decrease in progenitor, but the pool of normal stem cells were actually very similar to normal situations. And actually, when he went on to go a little deeper in the phenotype of the pure or the purest hematopoietic stem cells, actually, compared to normal, there was actually more quantifying wise, more normal residual stem cell in patients with AML. So that was reported, but we didn't have a mechanism. It looks like that in presence of AML, at least for the first stage of leukemia progression, you essentially, the normal stem cells are blocked in G0 and they don't proliferate. So Alexander, PhD in the lab, was interested in continuing and trying to understand these more mechanistically. And he developed different ways. The scaffold was one way, but also a more simple way, ex vivo, which is to co-culture AML with cord blood, CD34 positive, in presence or not of a niche component, which is the MSC here, to understand whether AML can directly talk to the normal stem cells and impede their development, or whether it was a cross-talk between the niche, the AML, and the normal cells. So it was quite simple experiments where you just put either AML and cord blood directly, or you put these with a co-culture of mesenchymal stromal cells. And essentially what was the readout is that we know that normal stem cells will actually don't proliferate in presence of AML. So we did these cell trace violet, stain the normal stem cell and look at their proliferation in contact with AML alone or in contact with AML and the stroma. And you can see quantification here that in contact with AML alone, there's a bit an impediment of the proliferation, but is exacerbated by the co-culture with mesenchymal stromal cells. So very short conclusion from that. He went on to look at what is happening. So we know, and he has done some transvalent experiments to show that the contact of AML with the stroma was important, but that he can separate the normal cells via transwell and did find the inhibition. So it was something secreted by the contact of AML with the stroma. So we went on to look at microarray analysis that was done ages ago in between stroma cells with AML cell line or patient samples. And it was interesting in the common of these, but also at something that is secreted. And he went on to see that there was potentially interesting potential markers of secretion, but he focused on staniocalcin, as staniocalcin has been shown in solid tumor to be a poor prognostic, the level of staniocalcin. And I am just showing you data to show that indeed we were able to show that staniocalcin is one of the players that actually inhibit the normal hematopoietic stem cell proliferation. And we were also able to obtain bone marrow fluid from these patients at remission versus at diagnosis. And you can see that staniocalcin level was higher. And if even you can just get peripheral blood from this patient compared to healthy donor from the creek, actually, we were able actually to see that staniocalcin is indeed a biomarker of showing that these patients will have actually an inhibition of normal hematopoiesis. He correlated that with the level of staniocalcin with thrombocytopenia in this patient, and there's a good correlation with that. So we conclude, and I just show you these. He went on to do a bit more molecular analysis of that, but what we show essentially is that AML induce in the stroma an hypoxia response, and staniocalcin is a target of IF. stannocalcin is being secreted in response to that co-culture, and stannocalcin directly affect normal hematologic stem cell proliferations. So I'm finishing up by just saying, a conclusive remark, mostly to say that, the heterogeneity of the leukemic stem cells between patient and within the same patient is really an obstacle for getting a new therapy that could really impede and decrease the leukemia burden of these patients and increase the survival. But by understanding normal and leukemic stem cells both intrinsically and by developing our knowledge of the environment between the crosstalk between leukemic cells and normal and the niche and normal stem cell, we hope that with these different angles, we will be able to actually target more specific the leukemic stem cells in the years to come and hopefully make a huge impact on patient survival. So I want to thank people in the lab. I hope I for sure didn't have time to speak to everybody in the lab, and I apologize for not showing your work. Past members that have been essential. I mentioned the work of Diana Passero, Kevin, Alexander, Antoniana. I like also to thank the STP at the quick BRF, FACS, Advanced Sequencing, Bioinformatics, but also the clinicians. Without them, we will not have patients' samples coming to the lab, and you for your attention. Thank you very much.